In this lesson, we'll be talking about basic chest anatomy and a few common pathologic processes in the chest as seen on chest X-ray. This is a nice example of a fine quality PA chest radiograph. You'll notice that the medial ends of the clavicles are symmetrically positioned in relation to the spinous processes of the upper thoracic spine. This shows me that there is no rotation on the image. The shoulders were rolled forward, which moves the shadow of the scapula laterally almost out of the lung field to give us the best visualization of the lungs. Along the midline of the upper chest, we see the trachea appearing as an area of decreased density projecting over the spine. The trachea bifurcates at the level of the carina into the right mainstem and left mainstem bronchi. This is helpful anatomy of which to be aware in the setting of endotracheal tube placement. You'll notice to the left of the trachea is a rounded structure representing the aortic arch. As we proceed down the midline of the chest, we see the right and left heart borders. On this normal chest X-ray, you might make a note of the size of the heart shadow in relation to the rest of the chest. There are certain pathologic entities that will enlarge the size of the heart shadow. Continuing in the central chest, but moving outward, we see the pulmonary vascular markings starting at the hyla and branching into the lung fields bilaterally. You'll remember that the lungs are very highly vascularized, and there is a robust network of vessels extending into the lungs from the central portion of the chest. Moving peripherally from the central chest, note the pulmonary vascular markings around the hyla, branching and tapering as the vessels extend laterally throughout the chest. You might also note that the pulmonary vascular markings are thinner or smaller in caliber in the upper lung zones than in the lower lung zones. This is due to the effect of gravity. The lung fields are generally denoted into the upper, mid, and lower lung zones, and in this case, the lungs are clear. We can see the vascular markings throughout the lung zones bilaterally. Along the lower portion of the chest, we see the diaphragm contours bilaterally, with the costophrenic angles along the lateral edge where the diaphragm contour meets the chest wall. We also note the bony structures of the chest, including the spine along the midline, the ribs bilaterally, the clavicles, the scapula, and the humerus. Lastly, this is an image of a female, and we see the breast shadows projecting over the lower lung zones. This is an example of a large right pneumothorax. You'll notice that along the left side of the chest, we see vascular markings throughout the lung zones as expected. On the right, there is a large area of abnormal lucency extending from the top of the lung zone all the way to the diaphragm, with the collapsed right lung positioned toward the midline. A pneumothorax is a pathologic process where gas enters the space between the lung and the chest wall, the space between the lung and the rib cage. As the rib cage is a fixed structure, as air enters the space and becomes pressurized, the soft tissue structures within the chest will be affected, as in this case where the lung is decreased in volume. This is a slightly more subtle example of a pneumothorax on the right. One of the hallmark findings of a pneumothorax is called a pleural line. In this case, a very thin white line is observed in the right upper lung zone, corresponding to the same position as the bottom edge of the right fifth rib. You also notice an absence of lung markings beyond that thin white line. Presence or absence of lung markings is not a definitive finding, however. On this image, we see a nice example of a right pleural effusion. A pleural effusion is abnormal fluid in the space between the lung and the rib cage. You'll notice that on the left we see a normal appearing costophrenic angle, and we see normal lung markings in the left lower lung zone. However, on the right, the diaphragm contour is completely absent, the costophrenic angle is absent, and there is abnormal density asymmetrical over the lower lung zone. This radiograph is an example of pneumonia, any process that causes the abnormal accumulation of fluid or cells within the otherwise normally aerated portions of the lungs will create an area of increased opacity. In this case, there is a large area of abnormal opacity in the right mid-lung zone, extending almost all the way across the transverse width of the right hemithorax. Pneumonia is an infection in the lung and can be caused by bacteria, viruses, or fungi, but it is important to note that the chest X-ray appearance alone is not definitive for pneumonia. Any process causing the abnormal accumulation of fluid or cells in the otherwise normally aerated portions of the lungs will create the appearance of increased density. This is our last image for this lesson. This is a nice example of a common chest pathology, heart failure with pulmonary edema and bilateral pleural effusions. You'll notice that unlike on the prior chest x-rays, in this case the heart shadow appears enlarged and along its left side is difficult to discern. The pulmonary vascular markings are obscured and there is increased density throughout the mid and lower lung zones in a symmetrical fashion bilaterally. There's increased density throughout both lungs that appears fairly similar from right to left. On the right, we can see the diaphragm contour, but there is blunting at the costophrenic angle. There's also an abnormal linear area of density in the right mid-lung zone, representing a small amount of fluid in the minor fissure. The minor fissure is a space between the right upper and right middle lobes. On the left, the diaphragm contour is completely absent and the costophrenic angle is obscured. In this case, there is probably a larger pleural effusion on the left than the right. Lastly, you'll notice that the opacity in the lungs is least pronounced in the upper lung zones.